IBS and IBD are two really similar acronyms, but they're two very different gastrointestinal disorders. So if you're feeling confused between the two conditions, or perhaps you didn't know these were two different conditions, then this YouTube video is for you. My name is Danielle, and I'm a virtual IBD dietitian. And in this video, we're going to compare both conditions, as well as demonstrate how nutritional recommendations are different for each condition. So let's talk about the key differences between IBD versus IBS. Inflammatory bowel disease, or IBD, is an umbrella term used to describe the conditions that involve chronic inflammation of the digestive tract. In inflammatory bowel disease, the inflammatory response results in gastrointestinal tissue damage. The clinical course of the disease may be mild and episodic or severe and unremitting. The two major forms of inflammatory bowel disease are Crohn's disease and ulcerative colitis, or UC. Irritable bowel syndrome, or IBS, is a functional GI disorder. This means that the condition is caused by changes in the way the GI tract works, as opposed to a physical abnormality in the GI tract, like in Crohn's or UC. So let's talk a little bit more about what is inflammatory bowel disease. An estimated 1.3% of U.S. adults, or about 3 million U.S. adults, have reported being diagnosed with IBD. Men and women are equally likely to be affected by the disease. While IBD can affect each person a little differently, here are some of the more common symptoms: persistent diarrhea, rectal bleeding, urgent need to move bowels, abdominal cramps and pain, nausea and vomiting. While IBD involves inflammation of the GI tract, it can affect your overall health and cause more serious medical issues. For example, loss of appetite, weight loss, low energy and fatigue, nutrient deficiencies, fissures, fistulas, strictures, blockages, and osteoporosis. And these medical issues can impact nutritional recommendations. How are Crohn's disease and ulcerative colitis different? Crohn's disease may involve any part of the GI tract, from mouth to anus, but approximately 50 to 60% of cases involve the distal ileum and the colon. In Crohn's disease, segments of inflamed bowel may be separated by healthy segments. In ulcerative colitis, disease activity is limited to the large intestine and rectum, and the disease process is continuous. What is irritable bowel syndrome, or IBS? An estimated 10 to 20% of the United States population has IBS, with about twice as many women as men being affected, to the best of our knowledge at this time. IBS is characterized by unexplained abdominal discomfort or pain that's associated with changes in bowel habits. Other common symptoms include gas, bloating, diarrhea and/or constipation, and increased GI distress associated with psychological and social stress. IBS subtypes are based on the predominant bowel habits and stool form. So, for example, irritable bowel syndrome with increased symptoms of watery stools and diarrhea is known as IBS-D, short for IBS diarrhea. Whereas IBS-C is irritable bowel syndrome with constipation, another common form of IBS that's associated with passing hard stools. People experience gas and bloating and straining and painful bowel movements and abdominal pain. Then there's IBS-M, or mixed IBS. So irritable bowel syndrome, mixed, going back and forth between diarrhea and constipation. And then there's IBS-U, or unclassified IBS, defined as patients who meet the diagnostic criteria for IBS, but whose bowel movements can't be accurately categorized into those other three subgroups. So that's when the patient reports that they rarely have abnormal stools. How do medical doctors diagnose IBD and IBS? For IBD, a combination of the following procedures could be used to diagnose the condition: endoscopies like a colonoscopy, flexible sigmoidoscopy, upper endoscopy, capsule endoscopy, or balloon-assisted enteroscopy. Then there are imaging scans like X-rays, CT scans, or MRIs, and lab tests like stool cultures or blood tests to check for inflammation or markers that could be abnormal. There are currently no pathophysiological tests available to adequately diagnose IBS. So instead, after the exclusion of other gastrointestinal diseases like IBD, symptoms play an important role in establishing a positive IBS diagnosis. IBS should be diagnosed by a medical doctor, so important, and the medical doctor should take a careful history and use the Rome 4 criteria. These allow IBS to be classified by the predominant symptom type like IBS-C, IBS-D, IBS-M, or IBS-U. Let's talk about flare-ups with IBD and IBS. Many people with IBD and IBS will experience a flare-up of symptoms that often leads to a diagnosis, although intermittent flare-ups continue after diagnosis as well. Flare-ups are usually when many symptoms become more apparent after a period of remission, such as pain or needing to use the restroom more often. So let's talk about nutrition for IBD. People with IBD are at an increased risk of nutrition problems for a host of reasons related to the disease and its treatment. And medical nutrition therapy can look very different for a person depending on their specific IBD situation. For example, if someone has Crohn's disease with severe strictures, the nutritional recommendations are going to look very different compared to someone with UC who just had a colectomy and now has an ostomy. As of right now, there's no single diet or eating pattern for reducing symptoms or decreasing the flares in all people with IBD. There are a variety of different eating patterns that nutritional research publications are starting to study in greater detail. They're what we call elimination diets, and some may work for some people, and as research methods are improving, some of those diets are starting to show some promising results. But these eating patterns can also be very restrictive, and none of the diets out there have been proven to work for everyone with IBD. What we do know right now is that many people with IBD report specific, individualized food triggers or food intolerances. But different guts appear to tolerate different foods differently with this condition. So a good example of this is my husband with Crohn's disease. He is completely lactose intolerant. Like, we learned that even the tiniest amount of lactose is going to cause him a bad time. But I've worked with many clients who tolerate dairy fine, and one client even tolerated dairy best. So at this time, it appears that different guts tolerate different foods differently with this condition. Let's switch gears to nutrition for IBS. Just as there's no single therapy for treating IBS, it's important to remember that there's no single dietary strategy either. However, a growing amount of research suggests that the low FODMAP diet is an eating pattern that has improved symptoms and quality of life for many people with IBS or irritable bowel syndrome. So what is the low FODMAP diet? The low FODMAP elimination diet is based on limiting certain short-chain carbohydrate-containing foods, including sugars, starches, and fibers, that some people can't fully digest and absorb. These short-chain carbohydrates are poorly absorbed in the small intestine, resulting in gas, pain, and diarrhea in sensitive individuals. This diet has been shown to help most people with IBS. We can't talk about IBD without talking about the huge risk for malnutrition. We care so much about malnutrition for IBD because it leads to poorer disease outcomes. Even mild cases of malnutrition can make it more difficult for the body to bounce back after illness. Malnutrition compromises digestion and absorption function in the GI tract and can cause growth delays in children with IBD. Here are some of the reasons why malnutrition is so prevalent in people with IBD. Complications experienced from the condition: abscesses, fistulas, strictures, ostomies, and beyond. This YouTube video won't be diving into the nutritional recommendations for each of those complications, but it can be very confusing for a person to know what to eat if he or she develops a complication like that. Medication side effects. IBD warriors may be taking quite an extensive list of prescription medications, many of which have big nutritional side effects. And reduced intake of food, either during a flare, from, say, increased symptoms, or from a fear of food brought on by a fear of negative consequences after eating said food. All those reasons can lead to an overly restricted diet and increases the likelihood of malnutrition and weight loss. Let's talk about nutrient deficiencies commonly found in IBD. 60 to 75% of people with IBD will experience one or more deficiencies. Several nutrient deficiencies are common for both Crohn's disease and UC, like iron, folate, magnesium, calcium, and potassium. However, in Crohn's disease, because the inflammation and disease process affect the small intestine and not just the colon, additional nutrient deficiencies like vitamin B12, vitamins A, D, E, and K, and zinc are commonly deficient. I can share that iron, vitamin D, and vitamin B12 are the big three deficiencies that I see repeatedly in my virtual private practice. Let's talk about nutritional deficiencies common in IBS. It's important to be aware that common nutritional deficiencies can arise with the low FODMAP diet if foods that are eliminated are not substituted with comparable items. So common nutritional deficiencies include folate, thiamine, and vitamin B6 from limiting cereals and breads, and calcium and vitamin D from avoidance of dairy products. Let's talk about the medical management of IBD versus IBS. So let's start with IBD. The goals of treatment in IBD are to induce and maintain remission and to improve nutritional status. Currently, the most effective medical agents include corticosteroids, anti-inflammatory agents, immunosuppressive agents, antibiotics, and anti-TNF agents. When thinking about surgical management of IBD, in Crohn's disease, surgery may be necessary to repair strictures or remove portions of the bowel when medical management fails. Approximately 50 to 70% of people with Crohn's disease undergo surgery related to the disease. Surgery does not cure Crohn's disease, and the recurrence often occurs within 1 to 3 years of surgery. The chance of needing subsequent surgery in the patient's life is approximately 30 to 70%, depending on the type of the surgery and the age of the first operation. This is important from a nutritional perspective because major resections of the intestine may result in varying degrees of malabsorption of fluid and nutrients. For example, in most Crohn's cases, the disease activity occurs in the ileum, so the last part of the small intestine. So if a patient needs the majority of the ileum removed, he or she may need to get his or her vitamin B12 lab values checked regularly because that nutrient is primarily absorbed in the ileum, in that last part of the small intestine. Now with UC, approximately 20 to 30% of patients will have a colectomy or removal of the colon. And if the whole colon is removed, this actually resolves the disease because without the colon, there's no more colon to be chronically inflamed with ulcerative colitis. Whether a colectomy is necessary depends on the severity of the disease and indicators of increased cancer risk. After a colectomy for UC, surgeons may create an ileostomy, a specific type of ostomy with an external collection pouch, or an internal abdominal reservoir fashioned with a segment of the ileum or ileoanal pouch, which spares the rectum to serve as a reservoir for stool. So that procedure very commonly is called a J pouch or an ileo pouch. Now let's talk about medical management for IBS. There's no specific therapy that works for all people with IBS. Generally, the treatment option is determined by the predominant bowel pattern and the symptoms that most disrupt the patient's quality of life. For example, different medications, dietary interventions, and/or mind-body therapies would be recommended if a person has IBS-D compared to IBS-C. Many people find that with these changes, symptoms improved and can be managed for long periods of time. That was a lot of information, so let's talk take-home message about IBD versus IBS. What does this all mean? Despite having similar acronyms and symptoms, the similarities between IBS and IBD stop there. Because of this, it's essential to get an accurate diagnosis, as treatments and nutritional recommendations for these conditions are very different. Make an appointment with your healthcare team if you think you have either or even both of these conditions. Did you find this YouTube video helpful? If so, please let us know by liking it and subscribing to this YouTube channel. Thanks.